Obstructive sleep apnea, OSA, is a common sleep disorder characterized by repetitive episodes of complete or partial upper airway obstruction during sleep, resulting in fragmented sleep and intermittent hypoxemia. It is estimated to affect about 25% of adults worldwide and is associated with significant morbidity and mortality. The pathogenesis of OSA is multifactorial, with a complex interplay between anatomical, physiological, and molecular factors. Normal sleep architecture is important in maintaining upper airway muscle relaxation during sleep. Patients with OSA have disrupted sleep patterns, including reduced REM sleep and increased arousals, leading to increased upper airway collapsibility and the development of OSA. In summary, upper airway collapse in obstructive sleep apnea is influenced by a combination of anatomical and physiological factors. These include small or abnormal upper airways, obesity, enlarged tonsils or adenoids, recessed jaw, and a narrow pharyngeal airway. Physiologically, the loss of wakefulness-related muscle tone, alterations in neuromuscular control, and increased chemoreceptor sensitivity contribute to upper airway collapse during sleep. Recognizing clinical manifestations and symptoms of OSA is essential. Classic symptoms include snoring, apneas, and daytime sleepiness. Symptoms can vary widely from mild to severe and may include morning headaches, mood disturbances, difficulty concentrating, memory impairment, recurrent awakenings, nocturia, and sexual dysfunction. Healthcare providers should be suspicious of OSA in patients with risk factors like obesity, hypertension, and metabolic syndrome. Accurate diagnosis of OSA requires comprehensive evaluation and the use of standardized diagnostic criteria. The gold standard diagnostic tool is overnight polysomnography, PSG. Diagnostic criteria are based on the apnea-hypopnea index, I, with an I greater than or equal to 5 considered abnormal. Treatment approach is determined by I, symptoms, and comorbidities. To accurately interpret polysomnography results in obstructive sleep apnea, key parameters such as the apnea-hypopnea index, I, oxygen desaturation index, ODI, and arousal index must be evaluated, along with sleep stage distribution and other relevant parameters. I values of 5 to 15 indicate mild OSA, 15 to 30 indicate moderate OSA, and greater than 30 indicate severe OSA. This comprehensive assessment helps in determining each patient's sleep architecture and potential impact on daytime functioning. Research has shown that obstructive sleep apnea, OSA, is linked to cardiovascular diseases, metabolic disorders, and neurocognitive impairments. OSA increases the risk of hypertension, coronary artery disease, arrhythmias, heart failure, insulin resistance, glucose intolerance, dyslipidemia, metabolic syndrome, attention deficits, memory problems, executive function deficits, and mood disturbances. OSA disrupts normal neuronal processes and impairs neuroplasticity, leading to cognitive decline. Diagnosing and treating OSA is crucial to prevent or manage these health issues. The main treatment options for obstructive sleep apnea are continuous positive airway pressure, CPAP, and oral appliances. CPAP involves using a device to deliver pressurized air to keep the airway open during sleep. Oral appliances reposition the jaw or tongue to maintain airway patency. Surgical interventions for obstructive sleep apnea may be appropriate for some patients with anatomical abnormalities. Uvulopalatal UPPP, involves removing excess tissue from the soft palate and uvula, while maxillomandibular advancement, MMA, repositions the jaws forward. These procedures can improve respiratory parameters and symptoms, but risks should be considered. Pediatric obstructive sleep apnea presents unique challenges due to differences in anatomy, pathophysiology, and clinical presentation compared to adult OSA. Adenotonsillar hypertrophy is the most common cause of pediatric OSA, with additional risk factors including obesity, craniofacial abnormalities, and neuromuscular disorders. It is important to recognize that untreated pediatric OSA can have significant consequences on growth, development, and behavior. Children with OSA are at increased risk of attention deficits, hyperactivity, poor school performance, and behavioral issues. Early diagnosis and intervention through adenotonsillectomy or other appropriate treatments are crucial to prevent long-term complications and optimize outcomes in this population. Once treatment is initiated, regular follow-up and monitoring are essential to evaluate treatment response, address side effects or complications, and ensure treatment adherence. Objective measurements, such as repeat polysomnography or home sleep apnea testing, can assess treatment efficacy and titrate therapeutic interventions as needed. Treatment adherence remains a significant challenge in the long-term management of OSA. Encouraging patients to consistently use CPAP or oral appliances and addressing barriers to adherence, such as mask discomfort or claustrophobia, can improve treatment outcomes. Monitoring for potential complications, such as mask-related skin irritation, aerophagia, excessive swallowing of air, or dental changes with oral appliances, is also important to ensure patient comfort and safety. Emerging evidence suggests that OSA is associated with chronic low-grade inflammation and oxidative stress, contributing to the development and progression of comorbid conditions. Intermittent hypoxemia, reoxygenation cycles, and mechanical stress imposed on the upper airway during apneas trigger the release of pro-inflammatory cytokines and reactive oxygen species. These inflammatory and oxidative stress pathways have been implicated in the pathogenesis of cardiovascular diseases, metabolic disorders, and neurocognitive impairments observed in OSA patients. Targeting these pathways through anti-inflammatory agents, antioxidants, or lifestyle modifications may hold promise as adjunctive therapeutic strategies to prevent disease progression and improve outcomes in OSA. Obesity and obstructive sleep apnea, OSA, often occur together. Obesity increases the risk of OSA by narrowing the airway. OSA, in turn, can lead to weight gain and metabolic problems. Managing both conditions can improve overall health. In conclusion, obstructive sleep apnea is a complex disorder that requires understanding of its causes, symptoms, and treatment. Collaboration among healthcare providers is vital to improve patient outcomes and quality of life.